All right, it is Gastrointestinal Pathology Day. It is winter 2022. It's Thursday. We're going to talk about gastroesophageal reflux disease as the star of the show. So here we go. GERD. And GERD stands for gastroesophageal reflux disease, and it occurs when people regurgitate or burp up stomach contents, which is mainly acid and pepsin, to a place it's not supposed to go, into the esophagus, right? Here's your stomach. There's a valve right here we've talked about, the lower esophageal sphincter. When food goes into the stomach, it gets sealed in there and it can't get out that way. But in some people, this gets really loose and it can burp up, and that's GERD, when acid and food particles and stuff get burped up into the lower esophageal sphincter. And that chronic bathing of the esophagus with acid, which is not made to withstand acid, it doesn't have simple columnar like the stomach has, which is designed to handle stomach. It doesn't have a gastromucosal barrier. It just has a kind of a modified stratified squamous, so it can't handle the acid. So you damage the mucosa and submucosal layers, and it hurts. There's nerves down there. There's the classic cartoon. Normally, someone fills up their stomach with food. We have a cutaway version. We can't see the rest of the food and liquid down here. But you've stuffed yourself pretty much with food and liquid. But no fear, normally this lower esophageal sphincter is pinched shut. This patient, it's not pinched shut, it's loose. And therefore they sleep on the wrong side, they lay on their right side, or they burp, or they do different things. It comes up. There's nothing to stop it from coming up. Or even if they try to burp, even the burping can burp it up. That's GERD right there. It's a problem with the lower esophageal sphincter. Lay people call it heartburn, and this is classically a burning pain over the sternum or the breastbone, over the xiphoid process, and sometimes into the throat. Mine, I have battled GERD for many years, and right now I'm GERD-free. Earlier videos I've done on this, and I wasn't GERD-free. I was on PPIs, but right now I have it beat again. Mine actually feels like it's more in my throat when I get it. It's in the sternum, but mine refers easily to the throat. So this is called retrosternal pain when it gets in any of these places, and it's a burning sensation, very uncomfortable. What triggers it? Many things can trigger it, but its classic triggering is after a big spicy meal with a red sauce, or Thai food, I guess, is really spicy, can do it, especially if you mix some alcohol in there with it. And it doesn't usually happen right away unless you have ulcers in your esophagus. Then you can have pain right away from the food sliding over your ulcers. But it typically happens about an hour and a half after a meal. Oh, I guess that's not what the slide is saying. We'll get to that. But if you have this burning breastbone pain for more than 2 times a week, you get diagnosed with GERD. That makes the kind of rough diagnosis of GERD. And what causes the pain, as we said, is the acid gets through the epithelial cells of the mucosal layer of the esophagus, and it burns the nerves in the in the lamina propria of the mucosal layer. So it gets through the epithelium into the lamina propria, and we went over the histology last time. And there's nerves in the lamina propria, and there's nerves in the submucosal layer, bigger nerves, and so it can become quite painful. So here's the little review. This is the lumen of the esophagus here. These are the folds where near the gastric mucosal, or where near the lower esophageal sphincter, where the esophagus is pinching together. But we have a layer of epithelial cells right here, specifically 3 layers. It's a modified stratified squamous. It's not keratinized like your skin is. And then right under that in green is the lamina propria, and that's where you have pain-sensing nerve fiber. So if you get acid burning away through here, it can light these things up, and it could send pain signals down the nerves, and those nerves go to your brain It's not, these nerves, by the way, are not very good at sensing pain. These are not somatic nerves. These are autonomic nerves. They're not very good at telling the brain where the pain is. So pain can be felt in the throat, in the xiphoid process, in the sternum, in the chest, over the heart. Some people in the back. Could be referred to many different places. And yeah, the tight junctions are what is believed to be overpowered too. It doesn't destroy the cells. It usually destroys the edges of the cells where the tight junctions are, which keep the cells together. All right, so there's just the acid. Some acid and pepsin's been burped up, and it's went right between the epithelial cells. Now we got a rip-roaring infection or inflammation here in the mucosal layer and in the submucosal layer, and this patient is miserable. So there's a couple subcategories which should talk about. If you go get an endoscope, put down your throat to see what has happened, we can make several diagnoses. So if you go down there and the esophagus is red in color, it's erythemic, that means red in color. But there's no ulcers, there's no holes in the mucosal layer. Then the diagnosis is reflux esophagitis, meaning inflammation. When you're looking down there, maybe it's red, but maybe there's some flat-out holes in there. We'll take a look at what those look like. Very painful. So then the diagnosis is ulcerative reflux esophagitis. And about 50% of the time when they go down there and they look around, they don't see anything. There's no redness. There's no holes. So then you get the diagnosis of nonerosive reflux esophagitis, which is NERD. That's the diagnosis of NERD. And that's a very common diagnosis. And that's actually not a great diagnosis because they're resistant to treatment. Kind of some epidemiology or fun facts about GERD. It's the most common diagnosis put forth by gastroenterologists. 20% of Americans have this diagnosis right now. So the population prevalence is 20% of Americans. That's a huge number. Typically hits people over 40, but I've known plenty of students who battled this. My own grandson battled this back when he was 8, 9 years old. He had run-in with it for about a year and it disappeared without any treatment other than some proton pump inhibitors. It definitely increases with age. The older you get, ligaments and tendons and muscles, they shrivel up and they become more flaccid, and that's the same with the lower esophageal sphincter. It gets loose and it can't hold the acid in the stomach anymore. An acute symptom strikes 40%, even a bigger number. Once a month, at least 40% of adults battle one bout of GERD. And if you do it really bad, the symptoms could last for months. My big flare-ups of GERD have lasted 5 years. It has taken me to get rid of it. And the last time I got rid of it in about a year and a half. And now I'm careful not to injure it again because it takes forever to get better. As of 2013, 11 million people in the United States received a prescription for a proton pump inhibitor. Interestingly, the degree of esophageal damage is not predictive of the pain and the disability associated with this. Some NERD patients who have nothing visible on endoscopic evaluation have horrible debilitating pain to the point they're getting anorexic because they don't want to eat anything. There's some research about not only is the sympathetic afferents that are stimulated, but the capsaicin receptors and the nerves that supply those might be involved with this. I took a bunch of that out because I don't think that's that important. So in addition to acid, some people get bile from the duodenum that refluxes into the stomach and then refluxes up into the esophagus as well. And bile is very nauseating. Its presence in the esophagus or in the stomach alone typically causes nausea to the point where the patient will throw up. Those patients have problems with the true anatomical sphincter, the pyloric sphincter. Pepsin, as well as hydrochloric acid, is also damaging to the esophagus. Let's not forget it's not just acid in the stomach, it's pepsin as well. Patients with a hiatal hernia. This is a hiatal hernia, which I think, did we talk about those yet? If not, we will talk about hiatal hernias, different types of those. Those greatly increase the chance for GERD as well because there's no lower esophageal sphincter. Lower esophageal sphincter is way up here. It's in the thoracic cavity where it doesn't work. Remember, the lower esophageal sphincter needs the crust of the diaphragm, the right crust, which you can see there looping around, and it needs the esophageal hiatus to give it some meat and some beef. In a hiatal hernia, the stomach slides up. The fundic and the cardiac region slide up. Well, it depends what type it is, but the fundic region can slide up, and there goes your lower esophageal sphincter, so you're going to get GERD. Almost guaranteed. Sometimes the acid can come all the way up. This is what initially happened to me, and I was having trouble lecturing, and I didn't figure this out. I didn't figure this out until I got this class. Even the Stanford doc I went to didn't tell me what the problem was. Oh, here's PPIs. He didn't even... I had to figure it out for myself. I figured it out. The acid was coming all the way up into my vocal cords. And to confirm that, I went to a throat specialist who stuck a scope down there. And I could see my vocal cords on this big TV, and there's huge ulcers on my vocal cords from the acid. And he goes, yep, you have bad GERD. You need to sleep in a recliner, or you need to stop that acid from coming up. And that's, in a nutshell, that's how I defeat the GERD when it flares up. I have to sleep in a recliner, sometimes for months, until this heals up. I could have the operation, but my wife's not too happy with me trying to have any operations, so I've been doing great. As long as I obey my rules, I do fine with it. So sometimes the GERD comes all the way up into the salivary glands and causes them to overproduce mucus. Plus, mucus is going to be produced from the mucus glands of the esophagus from being inflamed. So oftentimes you have mucus coming up all the time, and sometimes a weird mix of acid and mucus in your mouth, and that's called water brash. Kind of a complicated word, but it really means mucus and a sour taste of a little residual acid mixed in with it. The symptoms of GERD is odynophagia or dysphagia. So about 30% of people, because they have ulcers in their esophagus, or they have scar tissue that's formed from inflammation after inflammation after inflammation, they get to the point where they start to get a stenosis of the esophagus, which we've already talked about, and they can't slide food. Hurts to slide food, and the scar tissue physically blocks the sliding of food into the stomach. And then you can get dysphonia, like I did. There's some vocal cords there. Mine had big ulcers right on them. I remember looking up on that screen and like, holy smokes, that's the problem. This is the second ENT doc. The first one was old school. He couldn't figure out what it was, but the youngster who was, ironically, Stanford graduated, went to Stanford, they didn't figure it out, but the guy who had been out in practice a while figured it out. By injecting some methylene blue, I think it was, made the ulcer stand out. Anyway, so I had dysphonia. You can't talk if your vocal cords have ulcers on them. It's hard to lecture and talk. Other symptoms, burping, nausea, and vomiting. And I burp like crazy when my GERD is activated. I'm a burper as well. GERD versus heart attack or angina, pre-heart attack. So GERD is the most common cause of non-cardiac chest pain. So you think you're having a heart attack, and sometimes it's almost impossible, even in the ER, to tell, are you having a heart attack? Because of the heart attack, the pain is transmitted by those same sympathetic afferent fibers, which is terrible at telling the brain where the pain is coming from. And so you have to do blood work, and you have to look for troponin levels. You have to run an EKG to distinguish the two sometimes. So you've got to do a cardiac workup. Here's the timing, the symptom timing, as I said already. It's about 1.5 hours after eating, as long as you don't have ulcers. When you eat food, the food is typically basic, and it feels good Kind of feels good for basic food sliding over the esophagus, which might have some lingering acid on it. Kind of coats it. But after, depending on how fast you digest stuff, after on average about 2 hours, the acid is flowing. Or the average, I guess, 1.5 hours is the average. But the food gets, the acid gets flowing, and the pH drops in the stomach, and now you're burping, acid is splashing around as your stomach is powerfully churning up that food, and that's when the symptoms occur. Also tends to be worse after dinner, after that biggest meal of the day. What are some risk factors? I always ask these. You need to know, because you need to tell your patients, right? Once you graduate from chiropractic college, you need to tell your patients. You need to know about this. Your patients are going to have this. It's a very common problem. So eating and drinking the wrong foods, overeating, especially close to bedtime. I mean, if you stuff your stomach full of food, the food's going to be right up against the lower esophageal sphincter, so it better be strong. Even if it's a little loose, some food and acid's going to come right through that sphincter up into the esophagus. Eating right before bedtime is a no-no, especially on a full stomach. Falling asleep on your right side. If I was in class giving this lecture, I would make you all say, repeat after me. Well, let's say it right now. Repeat after me. Right is wrong. Right is wrong. I had a student a couple quarters ago say this completely changed her friend's life by doing this, who battled GERD. And all they did is start sleeping on their left side and stay on the left side as long as you can. If you sleep on your right side, there's nothing stopping the acid. The only thing stopping the acid from going up your esophagus is that lower esophageal sphincter. If you sleep on your left side, the fundus is there to block. I'll show you a picture. If you sleep on your right side, there's nothing there. Hiatal hernias and obesity. Obesity is a risk factor because that increases the pressure. All the fat pushes on your intestines and increases the intra-abdominal pressure. And that stimulates, kind of pushes the stomach up into it squeezes the stomach against the diaphragm and squeezes the acid right out of the stomach. Okay, so if you sleep on your left side, right is wrong, left is correct. If you sleep on your left side, the fundus of the stomach is typically downward. So if you still have some acid and juice and food in your stomach, gravity is going to push that stomach to the bottom here, and it'll bump up against the fundus. The lower esophageal sphincter, even if it's loose, you'll be okay. But if you flip over and sleep on your right side, see, this is wrong. Right is wrong. See how there's nothing there. If we blow this up, this is the acid in the food. There's nothing. This food is right against the lower esophageal sphincter. And so it can easily seep through and trickle up. So right is wrong. Some more food triggers we have to know. Alcohol, caffeine, spicy food, we already said. Red sauces, we already said. Chocolate. I have to be very careful with all of these foods. In fact, I don't even drink alcohol or caffeine anymore. It's just, I just can't handle it. It kicks my butt. High protein meals can turn on more acid. A heavy fatty meal can turn on more acid. But the big ones are alcohol, caffeine, spicy foods, chocolate, and red sauce. Another interesting thing, everybody has different abilities to feel pain. Some people don't have a lot of afferent fiber and they don't feel much pain. That's especially true of older adults. And that's not actually a good thing because they can have horrible GERD and not even know it until ulcers occur. Or even worse, they just have a routine endoscopic evaluation. There's nothing wrong with them. And they feel, and the gastroenterologist sees a Barrett's esophagus, which is precancer, or even worse, they have cancer. So not all people are symptomatic. In fact, one study found a third of patients with Barrett's esophagus were in for routine exam. They had no idea that they were getting their esophagus was getting really beat up from acid. They had no pain from it. I already kind of spoiled this slide, but the cause of GERD is a weakening of this, the lower esophageal sphincter. And we've looked at this diagram before. There's the diaphragm. The diaphragm needs to be right at the level of the lower esophageal sphincter to give it some beef. The right crust is wrapped around here, which is not shown in this picture, and this is pinched off. But if you have hypotonicity, tonicity is the tightness of a muscle, hypo means there's low tonicity, you're going to have GERD, whether you feel it or not. And we already said a hiatal hernia greatly increases the chances of GERD, specifically one called a sliding hiatal hernia. We'll look at those in the weeks to come. Unlike, and I cut these slides out, but the hypocontractile esophageal disorder, it's so rare I took it out. But those people don't have good peristalsis, and they have a loose lower esophageal sphincter. But people with GERD, their peristalsis is typically normal. It might be a little weak, but typically, probably 95% of the time, they have normal peristalsis. They just have no lower esophageal sphincter. What are some other things that can increase the chance of GERD? Well, just getting old, as we already said, your muscles get weak and they dry out, and the lower esophageal sphincter is going to lose its power. Alcohol consumption relaxes. It's a depressant. Any depressant, Valium, CNS depressants, chocolate, muscle relaxers, soma. And somas, you run into this, commonly prescribed for muscle spasm, people with low back problems. Hiatal hernia. We've already talked about that. Stress seems to be related. We're not exactly sure how that works. Stress seems to produce more acid, so they might just have more acid around from acetylcholine stimulating parietal cells. There's some weird relationship between osteoporosis and GERD that we don't have a handle on yet. It's not that the osteoporosis is causing the weakness. It's the same condition that's causing the osteoporosis might be causing the weakness of the lower esophageal sphincter. And some people have weak, lax lower esophageal sphincter. It's idiopathic. We don't know why. We'll look at ZE syndrome, Zoller-Ellison syndrome, which is an overproduction of acid from a tumor, usually in the pancreas. And then some of the esophageal motility disorders, like the transient lower esophageal sphincter relaxation, weak esophageal peristalsis. How would weak peristalsis increase the chance of GERD? Well, if you bubble up GERD, how do you get rid of the acid? Or if you bubble up acid, how do you get rid of it? Peristalsis, a secondary peristalsis, occurs just above where the acid is, and it tries to sweep it back into the stomach. So if you have weak peristalsis, your clearing mechanism from burped up acid's not going to be very good. It could be other differential diagnoses. Look at all the stars. I love this slide. Got to know this. GERD differential diagnosis, where it's not a GERD, but you still have that retrosternal chest pain or throat pain or heart attack-like pain. There's other things that can cause that. Medications, especially NSAIDs for chronic pain. Nitrates or calcium channel blockers for people with heart angina. They open up the coronary arteries to let more blood flow. Oral antibiotics are notorious for causing upset, and birth control pills, 4 very common causes of stomach upset, which may be misdiagnosed as GERD. Some super rare disorders, I just do this because I teach dermatology. I want you to start thinking of these words. Pemphigus vulgaris and bullous pemphigoid. These are common blistering disorders of the skin. They're horrible. They're rare, luckily. Bullous pemphigoid is the most common blistering disease of the skin. It's an autoimmune attack against the BP230 protein of hemidesmosomes, causes a wicked inflammation, and your skin, your epidermis and dermis, literally pull apart and cause these horrible blisters all over. That's also associated with GERD, and so is pemphigus vulgaris, and that's an autoimmune attack against desmosomes. That's even worse, more deadly. Eosinophilic esophagitis. I took those slides out because it's fairly rare, but some type of allergen, possibly food-related, milk is one example, triggers an inflammation of the esophagus, and you get an inflammation in the wall of the esophagus. It'll start triggering those pain nerves to produce action potentials, and you'll get the sensation of pain. How do you know if it's eosinophilic esophagitis versus GERD? PPIs will have no effect on eosinophilic esophagitis because it's not all about acid. It's just about an inflammation from an allergen. So you have to go do a biopsy down there to figure out what it is. Esophageal dysmotility syndromes, we already said that. Nutcracker esophagus, super crushing peristalsis in the lower part of the esophagus can set off those pain receptors. Maybe it really is. Maybe you have coronary artery disease and you're getting angina. Chest wall inflammation, sternocostal or costochondral inflammation from some chest injury. Pleurisy, inflammation of the pleura can do it. One of the gastropathies, or gastritis, sometimes they're called. We're going to talk about those different gastropathies. But those are stomach conditions. And they can, like E. coli, or like H. pylori infection of the stomach, or autoimmune attack of the stomach. That can also simulate GERD. Peptic ulcer disease, maybe you're getting an ulcer from overproduction of acid. That can cause GERD-like symptoms. Hypersensitive esophagus. Some people just have too many nerves and they feel too much pain, and you'll run into that when you're treating low back patients. Some people are they're professional, not athletes, but they're professional pain feelers. And so that could be it. Psychological conditions, so depression, anxiety, these people have way higher incidences of GERD, probably because of sympathetics being turned on. And rumination, some people have GERD and they have an injury and they can't stop thinking about it. I mean, if you think about your hand, let's think about your right back of your hand. Put your mind in the back of your right hand and feel, just try to feel every sensation in that hand. You might start to feel some weird things in there. So people with sciatica, I have to be careful of that too, because when I have a flare-up of sciatica, I'm feeling the sciatica, and I have to tell myself, quit putting your mind there. And I put my mind in the back of my hand, and I can imagine maybe some weird little pain if I think hard enough about it. That's rumination, focusing too much on one area. So people have to be careful with that. So we talked about NERD, so that's a negative endoscopic evaluation. And this occurs specifically when tight junctions are destroyed and acid can shoot down between the epithelia cells so quickly that it doesn't damage the surface, it damages underneath. And this is a tough group to treat. We said the prevalence is about 50% of people who have GERD symptoms and they go in for an endoscopy. 50% of them have a normal endoscopic evaluation and they're diagnosed as a NERD, nonerosive reflux esophagitis. And it's not really good. It could progress into real visible esophagitis or erosive esophagitis, but it may not. But this is a tough group to treat. They don't respond well to the normal therapies, H2 blockers, PPIs. Prokinex, we don't really use much anymore, but they don't respond to that. So many of them don't. In one study, they don't tend to progress into the erosive esophagitis, but some of them can. And so endoscopic evaluation does reveal redness or worse. We already said this. So if you have redness, you're diagnosed with reflux esophagitis. If there's redness and holes or ulcers, it's erosive reflux esophagitis, which is worse. And so here's a normal esophagus, and here's one with ulcers all over the place, and it's red and inflamed, so that's erosive esophagitis. So how do you make the diagnosis of GERD without using an endoscope? Well, the signs and symptoms are pretty accurate at figuring out when someone has GERD or not. So if they have that sternum pain that occurs 60 minutes, 90 minutes after eating a high-risk meal, that's a pretty good indication. If that occurs at least twice a week, then officially they are said to have GERD. Another way is to use Tums or any type of antacid. Tums are miraculous for me. Have them eat that same high-risk meal that has caused pain before, and right after they eat that meal, take as directed. Don't take more than directed, but you can take quite a few of these things. I mean, I just take a handful of them, but you have to be careful of kidney stones and such. But you can kind of snuff out that acid with these Tums. I'll tell you another trick that's not in the books. If I have a spicy, like Mexican food, really spicy meal, which I just had tonight, I will have a little burping of GERD unless I eat ice cream. If I eat a heavy dairy product, I know probably doesn't make any sense, but I'm convinced that dairy, like ice cream or frozen yogurt, it kind of neutralizes out the acid. That's not official. That's just unofficial advice. But watch out for the Tums because they can cause urolithiasis. They can cause kidney stones. Make sure you know that. So if you're a stone former, you have to be really careful taking Tums. Let's see. So another test, you can go into the lab and they can put a little wire down into your esophagus that has a esophageal pH tester at the end, and you go around for 24 hours. It has a little recording button. If you feel GERD, you push the button, and then they look at the chart. It records the pH. If the pH drops like crazy when you push the button, you're diagnosed with GERD. It has good specificity. If it's positive, you have it. If it's negative, you're not so sure because there's about a 15% false negative rate. Just like the COVID testing, like the rapid tests are about the same. It's about 80% sensitivity and about 95% specificity. So not that high of a false positive rate, but a fairly high false negative rate. All right, so they put this tube down. You wear it for 24 hours. We said that already. When do you need an endoscopic evaluation? What's the rule of thumb? Well, the rule of thumb is if over the last 3 months you've had one episode of GERD per week, every week for 3 months, so what is that, about 12 weeks in a row, you should have an endoscopic evaluation, because with that much acid coming up, it could start precancerous changes in that distal esophagus. Those precancerous changes, which we'll talk about next time more, is called a Barrett's esophagus. Okay, or it could even be something worse than that. Maybe it's esophageal cancer, eosinophilic esophagitis. Maybe it's a heart problem. You got to get it tested if you're having GERD symptoms that much. Here's a Barrett's esophagus. Here's an erosive esophagitis with big ulcers coming up. But here's the lower esophageal sphincter on this patient, right? This red color, that's simple columnar. That's the normal abdominal esophagus has this color. Lower esophageal sphincter is way down here. So this red color should be way down there, not way up here. So this is all tissue that has morphed. This stratified squamous has morphed into simple columnar. And if the histologist sees that the simple columnar matches the intestinal type of columnar, that's precancerous. That tends to morph into cancer pretty quickly. That's called the Barrett's esophagus. All right, let me take some water here so I don't wreck my voice. What about the treatment for GERD? PPIs immediately comes to mind. So acid suppression therapy is the cornerstone for all GERD treatment. It works really good. For me, it's always miraculous. It's coming off them that is the hard part. Proton pump inhibitors, H2 blockers don't work for me. They work in about 50% of people. I'll show you why. Prokinetics is associated with some bad change. Our best prokinetic drug was taken off the market because of cardiovascular. It was causing stroke and heart attacks in people. So that's kind of out of the question nowadays. To let the esophagus heal, you have to do some serious modifications of your lifestyle. You can't go to bed. You have to eat your big meal at lunchtime and eat a very small meal. You shouldn't, if you're having symptomatic GERD, if you have erosive esophagitis and you're trying to heal, you shouldn't eat anything 3 to 5 hours before bedtime. Maybe a small meal at the end. You should definitely not drink any alcohol. If you're having a larger meal, 6 to 10 hours is when that should be. If you go to bed at midnight, so your meal should be at 4 or 5 o'clock. If you go to bed at 9, which is older people go to bed much earlier, your meal should be at 2. 1 o'clock, 2 o'clock is when I usually, to this day, eat my big meal. If I eat my big meal at 6, 7, I go to bed at 9, 10 o'clock, I'll be in my recliner to start the night off. Don't overeat, especially close to bedtime, just said. Right is wrong. Absolutely do not sleep on your right side. We explained that already. Always go to bed on your left side. Stay there as much as you can. Avoid the irritating foods, which we've already talked about. Smoking seems to be related with relaxing the lower esophageal sphincter, so that might have an effect there. I've never smoked before, so I don't know that one. Sleeping with your bed up on blocks, about 25%. Reclined. If you can recline it like a recliner, great, but I've found that you can't get your bed up high enough. It never worked for me. Can't get it up high enough. Use a wedge. Now that will work. We can look at a wedge. When I went on vacation, I took this nice wedge with me because we had to eat late quite a bit. And it didn't have a recliner, and that worked really well. Here's one I have at home. I have back trouble, so this kind of irritated my back, so I can't really use it that much. But that probably would work if I could use it. I just use the recliner. Mine looks just like that, only a different color. If you're overweight and you have a kind of a protruding abdomen, you're going to have increased chance of GERD because of the stomach is being pushed by all the fat. So losing weight could help. And then take Tums to combat the problem. Maybe a Tums before you go to bed, just to prevent any nighttime acid. And there's other Alka-Seltzer, Maalox, milk of magnesia. Tums by far, I've tried most of these. Tums just kicks their butts. This chewing gum never worked, but there it is. H2 blockers, I've tried those. They're useless for me. Even the research says they work about 50% of the time. They are an H2 blocker, and there's a huge problem with that if you know your physiology already. Because what makes acid? What's the cell that makes acid? It's the parietal cell. And what stimulates the parietal cell to make it pump out acid? Well, histamine. Great. So if we block histamine, won't we block acid formation? Well, yes, that vehicle, that mechanism will be blocked, but aren't there other receptors? Aren't there other receptors? There absolutely are. Here's the histamine receptor, so H2 blocker blocks that. But what about gastrin? What about acetylcholine from the enteric nervous system? From stress can cause that. You don't block these two. So who cares about this one? If these two are pumping, you're going to get acid, and that's why H2 blockers don't work very good. Right, so H2 blockers, it's an older treatment. The thing with osteoporosis, H2 blockers don't have any relation to osteoporosis. PPIs might, as we'll find out. Who are the H2 blockers? Tagamet, Pepsid AC. The king of the H2 blockers was Zantac. But in 2019, they found that Zantac was tainted with NDMA, not date rape drug. That's MDMA or MDNA. NDMA is a carcinogen, and there it is. Not MDMA is ecstasy. Because I had a student go, "What?" And I said, "No, it's not that one. It's NDMA." So that one's still off the market. But I mean, personally, I wouldn't even mess with those things because the mechanism doesn't make sense to me. But yeah, the radinitine, the Zantac's been taken off the market. It looks like permanent now. All the lawyer commercials are out. Have you had cancer? Have you been on Zantac? Contact our law office. So we already said this. We talked about the H2 blockers, and they work great here, but you got 3 ways to stimulate acid production from parietal cells. H2 blockers don't do anything here. See the problem? Yes. Just talked about the problem. Great. Prokinetics, on paper, they sound really good. They increase the tone of the lower esophageal sphincter. They increase peristalsis to get rid of acid that might come up. Great. But the trouble is the cardiovascular effects. So the best ones have been banned in the United States, so they're kind of out. The king, by far, is the proton pump inhibitor. Now, there's a little smoking gun with osteoporosis with these things that we're not exactly sure. And Stanford's not afraid of it yet, their GI department, because I always ask about that. And I haven't been on them. I've been off about a year now. So I don't have to worry, but I'm sure I'll have a flare-up again and have to go back on them. Knock on wood, I don't want that to happen. But so number 1 treatment is proton pump inhibitors. They're about 80% effective, meaning completely effective. The big ones, there's some are now, they all used to be prescription, and now Prilosec is no longer prescription. You can get it right over the counter. Prevacid. Protonic, which is the one that works for me, is still prescription. This one, the other ones didn't work for me, but this one works really, really good for me. But the wild card is there seems to be some relationship between GERD, proton pump inhibitors, and osteoporosis. It's not official. There's just a little smoke possibly coming. It's not a full-blown fire yet, but there's some suspicion that they might cause or have something to do with osteoporosis. But we don't know if maybe it's not the PPIs, maybe it's just the GERD and osteoporosis seem to be linked. So we're not exactly sure what the story is with that. How do they work? They are absorbed through the stomach wall. You don't know how many clients I've had, and I always ask about GERD, and you don't know how many times they say PPIs don't work, and I ask them, are you taking it with food or without food? They always say taking it with food. If you take it with food, it's not going to work. You have to take it on an empty stomach with water because it's absorbed through the wall of the stomach. Wait at least 30 minutes before eating anything, and it'll work. The other thing is it takes about 2 weeks before it kicks in. And patients get frustrated and say it's not working, and they go off it. But you got to wait about 2 weeks before it will work. What does it do? It breaks the machinery that makes acid. Specifically, it binds to, remember, here's a parietal cell right here that makes acid. We studied this in physiology. So it binds to carbonic anhydrase, which makes acid. It makes carbonic acid, which dissociates into bicarbonate. And there's the acid right there. So it messes up this enzyme so you can't make carbonic acid. And it also goes to the proton pump itself and messes that up so it doesn't work. So a double mechanism, so very effective. All right, yep, PPIs are much better than H2 blockers. There's no NDMA problem, though, with proton pumps. So you don't have to worry about that. Problem is it takes 2 weeks, even 3 weeks in some people to work. So you have to be very patient. While you're waiting, you can use Tums, and you can try the H2 blockers. They may help a little bit, While you wait for these to kick in, you can use those other ones. Here's a classic New England Journal of Medicine. It's been tested several times, but the original study, I'll leave the original one up here. But you can see the best combination we ever had was a proton pump inhibitor with a protonic. And in this big study, after 12 months, 90% of patients had no GERD. But now we can't use the PPIs, so it comes back to about 80% better. People are better, completely better in 12 months who take just PPIs. And you can see prokinetics and H2 blockers, about 50% of people. But that's not much better than if people took a placebo, I would suspect. More recent data, 2014, the REN study demonstrated about almost 90% of patients with erosive reflux esophagitis, the more severe form of GERD, 87% got really good relief, so almost hit that 90% mark. NERDs, again, they don't do good. Only about 50% of NERDs get good relief from PPIs, 55%. 45% got no relief. So NERDs are a tough group to treat. Maybe there's something else going on with them. Maybe they're too sensitive to pain. Who knows what the story is there. Why aren't PPI? What about that 10% who don't get better? What's the thought on that? The thought is that they produce more acid. They make proton pump inhibitors quickly. So when you take PPIs and they knock out your proton pump inhibitors, and then you eat something, the body is smart. It'll make new proton pumps to counteract the ones that are broken. That takes time. By the time those are made, usually the food is gone and there's nothing to get acid worked up about. But maybe some people make them really quickly, and they have acid coming on later at night. So they have this nocturnal acid that's released. And so what's the fix for that? Some people double the dose of PPIs to fix that. Or you can just take Tums or an H2 blocker at nighttime and take the PPI in the morning. There's some other kind of experimental treatments for GERD where you can put a band around the abdominal esophagus. I'm not going to get into those because they're kind of not mainstream yet. But the gold standard by far is the fundoplication. And let's take a look at it. Basically, they cut all the ligaments, all the attachments that attach the stomach to the duodenum, and they wrap the fundus of the stomach around, like a hot dog bun around a hot dog, around the abdominal esophagus, and they sew it. They also put a couple stitches in the esophageal sphincter here, try to tighten up the lower esophageal sphincter to beef this up, and that's what it's about. And everything I just said. The goal is to fortify the lower esophageal sphincter by wrapping the stomach around it. Then you tighten the esophageal hiatus, tighten the right crust, everything I just said. If there's a hiatal hernia, you fix that while you're in there. And great. Now the obvious complication is, what if they make this too tight? And that's the complication. So they don't have GERD anymore, but now what do they have? Well, now they have a swallowing problem. Now they have dysphagia because they can't get food to pass from the esophagus into the stomach. So that's a problem. They get esophageal stenosis from over-tightening, which leads to dysphagia. But all in all, patients have good satisfaction from this. My Stanford primary doc, what is he? He's pushing 70. He's been in practice for over 40 years. And he swears that this is a very, very successful surgery. He really wants me to get that. But again, my wife says, no, you can sleep in the chair if you have to. You're fine. So, I'm doing fine. I could pretty much eat what I want right now, except coffee and alcohol. I stay away from that. All right, I think that's it. Barrett's esophagus we'll talk about next time. You guys have a great weekend. Hopefully I'll see you soon. Bye-bye.